then the proliferative phase, then the maturation phase. With the inflammatory phase, the goal here is to decontaminate and debride that wound bed by the body. So what we start off with is hemostasis. You've got your platelets come in, they start to form a clot, vasoconstriction occurs of the blood vessels to help allow this to happen, but you've also got concurrent vasodilation so that you can really increase the blood flow to that wound bed, and that's where you start to see a lot of that edema and wound fluid. There's a early inflammatory phase and a late inflammatory phase. The early inflammation occurs in that first 1 to 2 days where the neutrophils are establishing themselves. They're the first line defenders that kill some of the bacteria. They start to break down some of the extracellular matrix, and they help establish an immune barrier. Then in the late inflammatory phase, we otherwise call this the lag phase. That occurs about 2 to 4 days post the initial inflammation. That's when the neutrophils are primarily replaced by macrophages. These start to release growth factors. They reduce some of that exudate, although typically you're still seeing a good amount of exudate in general in this inflammatory phase. And they start to facilitate that transition to the next phase of wound healing, which is proliferation. In the proliferative phase, you've got several things going on concurrently. You've got an increase in blood flow. You've got several cells that are players here that start to help form an immature wound initial layer. And the primary cells are going to be fibroblasts, endothelial, and epithelial cells. They all form this fibrin scaffold, so they help deposit a new extracellular matrix, and you do start to see collagen production. Typically, this is very disorganized to start, and so you get haphazard arrangement of collagen. They're not really laid out in parallel lines. They're all over the place, and it's an immature collagen bed that eventually will mature later on. You also see angiogenesis, where you see lots of new capillaries and vessels forming. This phase is important because it's when we see our granulation tissue bed. And that you can see pictured here is a very nice, kind of robust, immature wound layer, but it's really nice because there's lots of blood vessels, it's typically cleaner, and it helps lay down the scaffold for you to either continue second intention healing for the mature phase of wound healing to come into play, or you can start closing these wounds if they're nice and healthy and clean. Question for you guys, can you see my mouse when I'm pointing to things? Danielle, do you see that?
Yes, I can see it.
Okay, perfect. You also see contraction in this proliferative phase where myofibroblasts start to align along tension lines, and then eventually epithelialization. So that's where the skin cells originally start along the edge of the wound and they start to mobilize and creep towards the center of the wound bed. That's why you typically see new skin form first around the circumferential edge, and eventually those cells migrate towards the center. As you can see here, the center of this wound still has some healthy granulation tissue, but the edges have started to contract with a new layer of keratinocytes or epithelial tissue. Lastly, the maturation phase is where you start to see remodeling and increase in strength and transition from immature to more mature collagen. So the collagen reorganizes itself. Typically, synthesis of collagen stops at around a month or 5 weeks in, but it can take up to a year for this collagen to mature, and that's where you see scar remodeling. The transition from collagen also occurs from a type 3 to a type 1 because a type 1 collagen is not only stronger, but it lays along the wound bed in a more parallel and stronger fashion. And in dogs, we typically don't appreciate this stage as much when the fur starts to grow back versus in humans, you'd obviously be seeing your scar start to disappear slowly over time. Regaining of tissue strength also occurs during this phase. So typically a wound does not regain 100% of the native strength pre-wounding. However, it tends to regain up to 80% of that original tensile strength, and that can occur roughly 3 months in, or sometimes a little bit longer. There are several impediments to wound healing. Local factors such as wound perfusion, depicted here with tissue necrosis, can obviously impede wound healing. You can also see hematomas and seromas with lots of pockets that can slow down wound healing. Systemic factors like obesity, autoimmune diseases, cancers, endocrinopathies like diabetes or Cushing's. Infection can slow down wound healing, especially with deeper, dirtier bite wounds. And there are three mechanical factors that are really important to wound healing, and that's motion, tension, and pressure. When you're seeing a lot of motion, tension, or pressure, you're going to expect some delayed healing, or you might have to play around a bit to decide, how am I going to close this wound, or can I even close it based on these factors? There are several tension lines throughout the body of a dog and cat, and that's depicted a little bit by this photo here. So where you close the wound and how you close it is very dependent along these tension lines. If you're working against tension lines, you're going to be more likely to have wound dehiscence. And of course, there's going to be greater tension and motion along the lower peripheral limbs, as well as over joints like the hock or the point of the elbow, and pressure as well. This is an example that I'll touch on a little bit later, but it's a wound that was right over the point of the hock. And you can see here that there's already epithelialization around the edge occurring, and a healthy bed of granulation tissue starting to epithelialize in the middle. But being right over the point of the hock, you're working against really all three: motion, tension, and pressure. So let's move on to open fractures and how we treat those. Infection is going to be the major cause of non-union or even delayed union of fractures, and therefore poor limb function. So it is really, really important to tackle this infection early so that it doesn't seed deeper into the bone. There are three ways to assess whether a fracture is open on an X-ray, and this is important because if it's open, then you want to make sure you're again tackling that infection head-on early in the process. The first is going to be visible foreign material, gas opacity within the soft tissues, and then bone penetrating through the soft tissues or wound out the skin, which is a pretty obvious one. This shows visible foreign material. So here we're looking at gunshot pellets, arrowheads, foreign material. Sometimes you're not going to appreciate that, but a lot of times, obviously, you will with the gunshots. You can see here, though, that you're not seeing much gas tracking in these soft tissues, right? So that can be a little trickier, but you can see the obvious pellets. Here, this was a fracture that I did. It was an open radius fracture, and the gas opacity is a little hard to see, but with these arrows, you can see some gas tracking in the soft tissues. There were some wounds there, so it was communicating with the fracture, and that does change how we talk to the owner about infection risk, implant removal potentially down the road, and just success of fracture healing and the potential for delayed healing because of tackling that infection as well. This is not a great photo, but here you can see the sharp bone end would be protruding through the skin, so bone penetration. There is a classification system for open fractures called the Castillo-Anderson system. This is one that started off in human medicine. We still use it in veterinary medicine, although there's another one that I'll touch on as well. And this is categorized into three main types of open fractures. You've got your type 1, which is considered an inside-out open fracture. That means you're going to see a really hard, blunt trauma, where as that fracture, that bone breaks, the sharp end of that break is going to perforate out through the skin, but there's not necessarily external wounding that occurs first. So these are typically smaller wounds. You can see milder soft tissue contusions or bruising. The next photo here I'll show. So if you don't like to look at fractures in humans, turn your head for a moment. But this is Kevin Ware, who is a famous basketball player. My partner told me about this, but this happened, I believe, about a decade ago, where he just landed wrong on the basketball court, and you can see that he sustained more of a type 1 Castillo-Anderson, although his wound is a bit bigger. But because of that blunt force, the bone just completely came out the skin there. I'll get that away. So a type 2 open fracture is an outside in, and these are typically accompanied with larger wounds and variably sized contusions. A type 3 is going to be a really severe outside in trauma. So gunshots, degloving injuries, these have extensive wound damage in multiple layers, typically the skin, sub-Q, and even muscle layers down to the bone, and often the bone can be comminuted. There are several type 3 subtypes of this open fracture system as well, and the type 3A is where you still have enough coverage to adequately cover the bone with the soft tissues. A B is where you have so much periosteal stripping and exposed bone, you're not going to be able to allow that to heal on its own by second intention or any sort of closure. You're going to need flaps or grafts. And a type 3C is where the arterial and vascular and nerve supply is so damaged that you're not likely to salvage the limb, and that's when amputation is indicated. The OTA fracture classification system also exists, and this has been adopted, I would say, more in veterinary medicine in the last decade or so. I learned about it in my residency, but it is used in humans more commonly. And this is a little bit more descriptive because it goes through the different layers that are damaged in an open fracture, and then 1, 2, 3 grades within each category that indicates whether there's mild, moderate, or severe damage. So principles of open fracture management, there are 4 main tenets to this, and that includes stabilizing the patient, reducing contamination while you do so. First and foremost, that's most important. And then eventually dealing with wound management, making sure that we're managing the systemic infection concurrently. And then eventually, lowest on the importance list is surgical stabilization. So stabilizing the animal, when you have a patient come in through the ER that has an open fracture, you're going to cover the wound if it hasn't already come in covered through the vet. If it has, just leave the bandage that's on, do your stabilization, take x-rays, whatever you need to do. The initial bandage here does not have to be anything fancy. The dog needs wound management eventually anyway. Slap some gauze onto the wound and wrap it with some vet wrap, and that's enough. Nosocomial infections are becoming more and more prevalent, similar to antibiotic resistance. There is a common species that there are several papers on that's becoming more prevalent in both human and vet hospitals. I may be butchering this name, Acinetobacter baumannii. This is a multi-drug resistant strain that has been found, and in humans, the mortality rate is reported to be up to 75% in humans that enter the hospital, become secondarily infected with this, and then unfortunately, typically have a pretty guarded prognosis. There are a couple of papers in veterinary medicine. There's one out of Switzerland where I think it was about 19 patients were admitted to the ICU. About 11 of those patients had systemic secondary or acquired infections with baumannii, and the other smaller population, about 8, had local infections of this species at the wound bed. And the mortality rate ended up being 58% in this study. The ones that were systemically infected had a 100% mortality rate, and the ones that had a more local infection at the wound bed had about a 33% mortality rate. So it is something that's really important, and this is why we kind of harp on making sure that wound is covered, even if it's a quick just slap on gauze and vet wrap, just to try to minimize the risks of acquired infections. After stabilizing the patient, we'll proceed with wound management. First and foremost, you want to place some sort of lube or protective barrier within the wound. Does not have to be sterile, just so that when you're clipping the fur, you don't get that fur inside the wound bed. You can also use saline moistened gauze. You want to make sure that you're clipping very wide. I always underestimate this, and a lot of times, you run into scenarios where you think you're clipping very wide, and then you go into primarily close this, and you see the fur kind of creeping in because you're really stretching that skin. So there's never such a thing as clipping too wide. Irrigation of the wound bed. It is really important to do this to decrease bacterial load, reduce any foreign body contamination. There is not a reported difference between using bottled or sterile saline compared to just tap water from the sink. So especially in those first several days of a dirty wound, you don't have to bother with any sort of sterile saline. You can even use tap water. The importance here of it is to focus on a low pressure, high volume irrigation. And that's because if you start really squirting the wound bed with very high pressure, not only can you potentially damage any healthy cells that are starting to form in that wound, but you're also kind of spritzing bacteria that are hanging on around the fur and the skin of the animal and potentially then contaminating the wound bed further. So the goal is a low pressure, high volume system, and you're not going to measure the PSIs. The ideal PSI pressure would be 7 to 8, but typically that's achieved with either putting like an 18 gauge needle on a moderately sized syringe or using a bottle of saline and poking holes at the top and just manually using that pressure. You can also attach a line and needle to fluids with an actual pressure bag. Peri-wound prep after lavage. This is really important because you want to reduce the contamination around the wound bed so that it doesn't enter that area. The goal here is not to use chlorhexidine directly on the wound. Most of our chlorhexidine scrubs are going to be about 4%. You do not want to wipe the wound with that or even put the chlorhexidine directly into the wound. That's very abrasive, and it can kill off the healthy fibroblasts that are trying to heal the wound. Reports show that at greater than 0.5% concentration of chlorhexidine, this is lethal to fibroblasts. So ideally, you want to use a solution that's even lower than that in terms of dilution at about 0.05%. So you're only here going to prep the peri-wound around the wound itself. Be careful not to get chlorhexidine in the wound. Debridement after prep and irrigation, you're only going to debride what's not viable. You have to be careful here, especially with wounds along the periphery, because if you start over debriding day one, well, you haven't allowed the tissues to fully declare themselves, and some of those questionable areas may actually come out to be healthy and don't need debridement, and now you've lost your chance to primarily close that wound in a few days. So it may take fully 3 to 7 days to fully establish tissue necrosis. So there's that chance for delayed healing or delayed necrosis that occurs. So sometimes just if anything under debride, and then you can always debride more later. Covering the wound. So once you get down to putting a wound bandage on, there's different sorts of primary layers you can use, and I'll touch on that a little bit later, but it is important to use a primary layer that's non-adherent so that you're not removing those healthy cells on the wound bed. That includes honey, adaptic, calcium alginate, and other dressings. Never close a primarily dirty wound. So for the most part, you should not be closing bite wound abscesses day one when they come in. I would argue even over a drain, because then you are still closing the area. It hasn't had a chance to fully declare itself. That might reopen fairly quickly and abscess. So allow especially with bite wounds, allow those tissues to declare themselves. Puncture wounds typically have a lot of trauma deeper in the sub-Q that you're not going to appreciate day one. And so manage those with tie-overs or some sort of bandaging, open wound management. Give it 2-3 days, 4 or 5 days, and then eventually close. So culturing, just to briefly touch on this, if the patient is going to surgery within a day or two, I would avoid culture altogether, because we're always going to culture intraoperatively, and the culture that we obtain is not just a swab, but a deep tissue culture, and that's going to be more representative of the residual bacteria hanging out in that wound bed that we can then tackle the infection with. If you are going to culture, and I think most of the time you can, that's fine, especially if the patient's not going to surgery or it's not going to surgery for several days. Make sure you're always culturing after lavage and debridement. You never want to just see the patient through the ER, pop the little probe in and culture and call it a day, because a lot of that bacteria, I mean, the dog's coming in from a dirty car or the environment, a lot of those bacteria that are sitting there on the skin or on the wound bed are not actually going to cause an infection. So contamination does not actually equal infection. If you do culture as well, make sure you're doing it post-debridement, post-lavage, and that will dictate what kind of long-term antibiotic therapy you should use. This paper looked at 64 dogs. Their question was to answer, well, what is the value of taking initial cultures of open traumatic wounds? And Valerie Johnson is actually a criticalist at Michigan State, so she's on this paper, but they looked at a good amount of dogs where they took cultures before lavage, after lavage, and then down the road during surgery. And the top result here, I mean, this makes sense. Fewer bacteria were cultured post-lavage than pre. That makes sense, right? We're rinsing away a lot of those superficial bacteria that don't actually go on to cause an infection. It's important to note, though, that in almost a quarter of these patients, an infection was diagnosed later. And that may have been, from post-lavage to intra-op, or it may have been if the dog never went to surgery at multiple times where a culture was taken. So later during the wound healing, but in almost a quarter, the subsequent cultures did not correlate with those that were cultured previously. And so I think that just brings up a good point of, just because we culture a certain bacteria, maybe at, the first day of wounding, that's not necessarily predictive of what's going to happen in terms of infection of that wound bed a week or two later. So sometimes when we see wounds that maybe are dehiscing or they're not healing as much as we'd like, we should take another culture just to see, well, what do we actually need to treat? Are we actually treating what's representative of that wound bed? And sometimes I think that also means, well, maybe let's not rush to culturing day one. Let's, again, if this dog's going to surgery, wait until we get that deeper tissue culture in surgery. Systemic infection management, this is also really, really important because giving antibiotics reduces the infection rate of wounds and open fractures by 59%. And there is a golden period in medicine that we talk about where you want to give antibiotics within 3 hours of presentation, and that will decrease your infection rate substantially. Anything greater than 4 is noted as not as good. The infection rate nearly doubles. So it goes from less than 5% at under 3 hours to 7.5% at anything greater than 3 hours. In humans, the protocol is typically to start giving IV antibiotics within 60 minutes of presentation. And that's what I would encourage us to do here. I mean, obviously there's a lot of stabilization that has to happen, but when you're setting that catheter, drawing blood, you can immediately get unison pulled up and get that going within an hour, ideally, but at least within the 3 hours. Not starting this does risk septicemia and then consequences of delayed healing of the fracture and persistent infection later. Finally, surgical stabilization when everything else has been controlled. The type of fixation will, of course, depend on the infection and the type of fracture. You have to consider that if you have a Castillo-Anderson's open fracture that's maybe graded 1 or 2, you can probably still get away with using a bone plate or internal fixation. But if you've got a grade 3, and something that requires or something that has a much deeper and severe infection, then you probably don't want to consider putting in an internal implant. You might want to lean more towards an external fixer, or at least talk significantly to the owners about having likely to remove that implant later, as it will likely.
Dr. Bauer, can you hold for a moment?
Antibiotic therapy, it really depends how long you're going to use antibiotics postoperatively for these fractures on how deep that infection is. Typically, when I have an open fracture, I like to err on the side of caution and use antibiotics for 6 to 8 weeks to minimize my implant-associated infection. With deep bone infection like osteomyelitis, you do want to have the dog on antibiotics for at least 2 months. Sequestrum development can occur with these types of open fractures. A sequestrum, as you can see here on the photo, is a piece of typically cortical bone that starts to necrose or it dies off, but it can get trapped within the bone, and then it can set up shop for this reaction around it and this secondary infection. And this halo effect around that is what we call an involucrum. And then if you have a draining tract coming from that area, that's going to be known as, and you don't really see one here, but that's going to be known as a cloaca, with infection draining out to the skin. And that can be bad because if you develop a sequestrum, you often have to go in and potentially debride that piece of dead and infected bone. And again, with an infection and an open fracture, you risk fracture instability, fracture failure, implant infection, deeper bone infection, and delayed or non-union of the fracture. Time to surgery. Historically, with open fractures, there was this theory of we have to jump into surgery within a 6-hour window in order to minimize infection risk or it becoming very severe. There's really no paper that indicates the 6-hour time frame, so we're not sure where that comes from. But recent papers have shown no significant difference in infection rates between fractures operated on before or after 6 hours. And in addition, there's been no correlation between the time that you first debride a wound associated with an open fracture to then developing a heavier infection. However, we would argue that you still want to debride and clean up that wound within the first 24 hours of presentation, and then surgery can follow within 3 days or even longer if the patient's not stable. Overall, with open fractures, we talked about always stabilizing the patient first with our 4 wound tenants. Cover that wound haphazardly, nothing fancy. Start antibiotics, ideally within 3 hours, but even better within 60 minutes. Practice appropriate wound management principles, making sure we don't put chlorhexidine in the wound, lavaging well, and bandaging appropriately. And culturing at least after you do the wound lavage and debridement, but if the patient's going to surgery quickly, then you may not even have to do so. Next, I'm going to touch on soft tissue wounds. Some of this will be overlapped with, of course, open fracture management because the wounds can be similar, but there's some additional information here. So there's different types of soft tissue wounds, right? We've got categories of abrasions, which are partial thickness wounds. We've got punctures, which are small, but they can be deceiving because they can cause deep tissue damage. These are going to be gunshot wounds, foreign body, bite wounds. Lacerations are sharp incisions. They may be deep, but a lot of times they're cleaner than bite wounds or other types of injuries. It really depends on what the dog lacerates itself on. Fun fact is that the most common type of laceration that occurs indoors in dogs comes from radiators, like the edge of radiators, where they'll be sitting under there and all of a sudden they'll get up and the back of their hock will form a laceration, or they'll get a calcaneal tendon rupture there. These can be less infected, like let's say the dog just cuts itself on a piece of glass or something that's not like a dirty bite wound. You may be able to close these day 1. Degloving injuries, this occurs with extensive loss of skin and tissue. There's a difference between anatomic and physiologic degloving injuries. Anatomic degloving injuries are going to be what you see here on the photo, where you get complete loss of your skin, sub-Q, even extensive loss of some of your muscle down to the bone. And there may be a flap hanging on that's necrotic or no skin left there whatsoever. A physiologic degloving injury is one where the skin and subcutaneous layers are lifted off of the underlying muscle fascia and bone, but the skin itself is still on the animal. It's just become non-adhered. So that also typically leads to loss of blood supply, and eventually you have to debride that, and it's typically not usable for closure. Thermal burns, all sorts of different burns, superficial and deep. And then there's the category of decubital ulcers, which is compression of tissues over bony prominences. There are different types of closure for soft tissue wounds. There's what we are most familiar with, which is primary closure. That's what we do for most of our surgeries. It's otherwise known as first intention healing, and this is where you get that clean, viable tissue. You can close it right away. There is delayed primary closure, and this is within the first 5 days of wounding, but before a granulation tissue bed has formed. These wounds are typically less contaminated, and you're able to just do a couple of bandage changes and then close that wound. Then we've got second intention healing, which is typically a contaminated wound where you can't close it primarily because it's very dirty. Maybe there's too much loss of skin, too much tension and motion, so you're not going to primarily close it. You need several rounds of bandage dressings and debridement. And not to be confused with all our first, second words, there's third intention healing, which is otherwise known as secondary closure. And that occurs when you close a wound after that 3 to 5 day window when granulation tissue has already formed on the wound bed. So this is an example where we might need to use some tension relieving techniques using bolster sutures and other types of techniques in order to stretch that skin before closing it. In the meantime, this nice cobblestone granulation tissue has formed, and then you're closing the wound. So different factors of when do we close a wound, when do we not close a wound? Well, of course, you have to take time into consideration. If it's just happened, the dog walked through your clinic and everything's clean, you can maybe culture and close it primarily. If it's a more chronic wound, you may not be able to close it at all because there's been lots of skin and muscle contracture. So now you have to deal with delayed healing and second intention healing. Degree of contamination, we've talked on this. Bite wounds, don't close them right away. Anything that's really dirty, give it some time to declare itself. Or if you have a dog that's been, let's say, hit by a car or dragged by a car and has lots of those road rashes and abrasions and bruising all over its like thorax or abdomen, then you may want to give it that, 3 to 7 day window to let all those tissues declare themselves. And you can actually take a marker and you can denote the outline of where you're seeing the current bruising or discoloration, and you can monitor how much that spreads over the coming days. Status of blood supply. If you've got a good blood supply, you may be able to close it more quickly. Is the patient stable? Of course. If not, we wait. And then there are some consequences of second intention healing. This is an example of contracture where the kitty was no longer able to really use these back legs. So there was open wounds along between the stifle and hocks, and then that extended into the caudal abdomen. And because this was allowed to heal by second intention, all that contracture happened, and then it reduced function mobility of those limbs. Also with implant exposure, this was a patient of mine, Boomer, from a couple years back, metacarpal fractures that were managed with bandaging for many, many weeks. And the tricky part here was you want to be able to close over an exposed implant. You can see the plate right here. But you can't because there's not tissue there, there's not enough skin. And so that's another consequence of second intention healing here, is that now we're dealing with an implant infection and the plate's likely having to come out. Let's touch a little bit on primary wound healing agents. So we've got honey, medical honey. This is really nice for those initial very exudative wounds, the dirty wounds that first come in. You do your first line of debridement lavage, and then you can place some medical honey. It's nice because it has free radicals to kind of scavenge some of that dirty tissue. It also has 0.003% of hydrogen peroxide to help heal the wound a bit, and antimicrobial effects. So it's really good for those exudative wounds, but you do have to do typically frequent dressing changes with the honey. So I like to use this for the first couple days until we've established a little bit of a healthier wound barrier. Maggots, medicinal maggots. So this is interesting. I haven't personally used these in residency or here, but this would be a good indication when you have a patient that's very unstable, and you can purchase medicinal maggots and throw them in the wound bed. And the maggots that are used are from the green blowfly. And that's because this specific larva that's used does not damage the healthy tissue, only the necrotic, dirty tissue. So that's good. But you can use this again in patients that maybe aren't stable. You can't sedate for wound management daily. Throw some medicinal maggots in there, cover it up, and allow that to have effect. Silver dressings, these are used for more mildly to moderately exudative wounds. They can be impregnated with antimicrobials. Silver with an alginate combination is also nice. Both silver dressings and hydrocolloids are hydrophilic, so they help pull out fluid from that wound bed. And again, these are used for mildly to moderately exudative wounds. The hydrocolloids are typically foam-based dressings, and you can see here when you pull them off that wound bed, they can form this green mucoid discharge. That doesn't mean that the wound itself is actually looking worse. In fact, this looks better. It just means that it's pulling all that nasty exudative material out of there, so it's actually doing its job. I love calcium alginate. I really like to use it after the first few days where honey might need to be used for that initial dirty wound. Once the wound starts to establish a little bit of a healthier tissue, then I transition to calcium alginate. And what's nice, so this is used for still moderately to severely exudative wounds, so you can still pull fluid, it's hydrophilic, but what's nice is it also enhances granulation tissue formation. So when I'm in that kind of mid phase of, okay, the wound's not not as dirty, but I'm not quite ready to close, or I'm still waiting for granulation tissue to form. Let's speed that process up. Let's put some calcium alginate on. And what's really nice about it is that you can leave it there for 2 to 3 days while it still has an effect, so you can reduce the frequency of your dressing changes. This chart comes from Tobias, which is our veterinary Bible. So if anyone wants this, I can send this to you. But it just kind of goes through and lists different dressing primary agents and how they're effective and what phase of wound healing and different products. This is a little bit older though, so there's newer products that are out there. But honey here is used in that early inflammatory period. You've got your silver, which is also used in the inflammatory period. The alginate down below is nice for repair. Again, it can promote that granulation tissue. A little plug on Veterinary. I love this stuff. This is probably one of my favorite wound dressings, and it is a hydrogel. So it's a hypochlorous acid that has antimicrobial effects. And what's nice is that it's moisture retentive. You don't want a wound to dry out, but you don't, of course, want it to be overly exudative with bacteria, but you do want it to retain some moisture to progress healing. And this does promote epithelialization. So when I have a healthy granulation tissue bed, this is when I like to transition to Veterinary, especially once the granulation tissue matures a little bit, it becomes smoother. It's not as cobblestoney in those first few days where it's very bloody. I like to transition to this. And in those cases, when the wound bed has become a little more mature, but it just needs to finish off the healing by forming that new epithelial layer, I will send owners home with this and say, please apply this to the wound 3 times a day to start, at minimum 2 times a day, and they can monitor it. And so sometimes you can even get away with not putting a bandage on these patients anymore if the wound is smaller, it's in a more mature phase of healing. And I personally like the gel here on the right better than the spray. I just had Sue buy some gels, and I love them because with the spray, it can kind of run down the surface if the owner's applying it. The gel tends to stick a little bit better. But I can't tell you enough how much I love this stuff, and I'll show you some examples here of how well it works. You can use it really well for chronic wounds. I didn't share this as an example with photos, but I recently had a consult on a shepherd that had a wound on its dorsal carpus from July of 2024. And I just saw this dog maybe a month ago. And the owners were just getting very frustrated because they can't keep the shepherd too quiet. They're elderly. They've gone to several vets, and it's just nothing seems to be working. They've kept wrapping it and wrapping it. I sent them home with a bottle of this, and I said, keep a cone on, here's some heavier sedation, apply this 3 times a day. And they just sent me a photo last week, I believe it was, which is about 2-3 weeks since seeing them. And the wound is already 50% reduced in size, and it had not changed in size from July through February. So it's really does wonders. This is a case, this is Pacer. He's a canine patient or a police dog. And we had to remove a mass off of the point of his hock, so his calcaneal region. And of course, because he went back to work, it's hard to keep him inactive. He opened up that incision, but then it became hard to close it again. We tried to put some staples in some areas at the top here. You can see where it healed okay, but right over the point of the hock is where it just opened up, and we didn't have enough skin to close. So after bandaging with soft padded bandages and some alginate on that primary wound bed for a few weeks, we got it to a state of healthier, more mature granulation tissue. And you can even see a little bit of epithelialization around the edge here starting to form, but we wanted to speed this process up. So we sent him home. At first, the police officer was putting some Vetericin and still covering it with a little bit of gauze and vet wrap and a non-adherent pad before that, just to keep it wrapped because he was still working and getting into dirty grass and dirt. And then we eventually, as the wound shrunk, we had him just keep the bandaging off and just spray the Vetericin gel on it a couple times a day. And after about 3 weeks, this is what it looked like. So took a little bit of time, but I mean, it turned out beautiful, and it's mostly epithelialized. And I hadn't heard from him since then, but the dog was doing well at this last check-in. Briefly on bandaging and drain placement. So there's different types of bandages that we can use. We've got tie overs, cross your heart or body bandages, Robert Jones bandages, and wound vacs. Layers of a bandage, you've got 3 layers, your primary, secondary, and tertiary. The primary layer is going to promote that moist wound environment. Those are the primary agents we talked about, the honeys, the alginates. They're going to help with debridement, pulling out that exudate, forming granulation tissue bed, and epithelialization. The secondary layer is your absorbent and stabilization. So that's typically going to be your cast padding, your cling, if you need to put a splint on or a cast. And then your tertiary layer is your porous material, and that's your vet wrap for evaporation. And it also helps reduce bacterial growth within the bandages. It doesn't trap all that moisture and bacteria in. A little bit on wound vac. This is also known as negative pressure wound therapy. So in general, the process is putting a foam on directly on the wound bed and then a firm occlusive dressing over top. That is connected to tubing that applies negative pressure through this mechanical unit you turn on. You can have that set to anywhere between -50 to 200 millimeters of mercury. The average usage is about at -125. And what this does is it pulls and pushes and puts stress and strain at the wound bed to stimulate more quicker transition into the proliferative phase of healing, where you get that granulation tissue bed so that you can close the wound more quickly or just allow it to heal more quickly by second intention. This is also very useful over skin grafts, fractures potentially if you have delayed healing or open fracture wounds, tight closures, and in humans, they use it a lot for burn patients. What does it do? It improves wound perfusion, reduces edema, it stimulates that granulation tissue, it reduces the bacterial load, and it again pulls out some of that extra wound exudate to allow for that healthy bed of granulation. The benefits of using a wound vac, it can be costly to place it to start, but you can achieve multiple days between bandage changes by having it on, and therefore the reduced need of sedating the patient, especially if they're critical. It also improves that wound bed so that you can hopefully get in and more quickly close it and get that wound more quickly closed up and healed, and it's typically well tolerated, less so in cats though. This was a paper, I think 2014 with Dr. Pitt and Stanley out of Michigan State. And they just looked at different types of wounds managed with the wound vac. 76% of them didn't have any evidence of granulation at the time of placing the wound vac. By the end, 96% had healed after using this, and they healed pretty quickly. The wound vac was on for a variable amount of time, from a few days to a couple of weeks, but it allowed them to close the wound primarily more quickly. And once they closed the wound, it was all healed within 2 weeks. So they had less of dehiscence and infection complications. And lastly, a little bit about drains. So in general, when you're using drains for wounds, I mean, there's an indication for them. Sometimes you don't need them. You need them for deeper pocketing, right? If you've got excessive exudate, you don't want to close, again, those primarily dirty wounds. I would argue that for bite wounds, you don't put a drain right off the bat, day 1 or day 2. You manage it with a tie over, some sort of wrap. Let some of that infection be controlled with antibiotics. And then after a couple days, go ahead and close it over a drain. There's a difference between open passive and closed active drains. In general, the open passive drains are the Penrose drains you're going to see. They're made of latex, so they can be very inflammatory and cause an inflammatory reaction, or also incite a secondary infection at the wound bed. A red rubber can do that as well. But the open drains work through gravity. So there's a place to use them. You're not going to use them right over the dorsal back because that's not really a gravity dependent location. I don't like Penrose drains, and because for multiple reasons, they can cause nosocomial infections. They're open to the environment. I mean, if you're going to use them, you can wrap the whole thing with a padded bandage afterwards, so the exudate instead absorbs into the bandage instead of the environment. But these can be frustrating for owners, difficult to manage at home, very dirty. Again, they're open, so you can get the environmental bacteria contaminating the area, and sometimes they don't work well. And if you have a hospitalized patient, I would recommend not using them really ever, because if the dog is sitting there in the kennel and you've got an open drain leaking everywhere, their neighbor may get some of that contamination, or potentially that dog that's sitting already in a hospital environment that is already at risk for nosocomial infection can get one more commonly. Closed active drains are great. There's all sorts of sizes, so you should be able to use those regardless of the size of the wound. These work through active suction. They allow for less contamination, and you can allow them to exit next to the main incision instead of through it, so you have less of a chance of that incision dehiscing or that drain tube causing an inflammatory reaction for it to cause problems at the incision. And you can see placement of some of these JP drains here. This is neat. You can always, with tiny, tiny wounds, use a butterfly catheter as a closed suction drain. You would take the end of the catheter and fenestrate it here with a few holes, and then you would put that in the wound bed. This would exit adjacent to the wound bed with a needle that you would then put into a tube in order to allow for that negative pressure. I typically would tie these butterfly wings to the actual tube with tape. It's not the most perfect contraption. JP drains are nicer. The small JP drains are nice, I think 3 millimeter or so. But if you're working with limited equipment, you can always try this. I used a couple in my residency and it worked pretty well in those small cases. A few fun facts to finish the presentation. Surgical risks of infection. So the risk of a infection at the incision site doubles for every additional 1 hour of surgery time. For every 1 hour of anesthesia time that's additional, it increases by 30%, and also by 30% for every additional person in the OR. So just things to keep in mind. With the really long, for example, open fractures or complicated fractures or any sort of surgery that has a wound associated with it, we have to be aware, well, if I'm in there fixing an open fracture for 3-4 hours or an elbow fracture for hours, that I'm going to be more likely to put those dogs on postoperative broad spectrum antibiotics for just a short period, a week or two, in order to minimize an implant associated infection. So just some food for thought. And with that, I'll take any questions.
I don't have a question for you specifically, Dr. Beulah, but I do have one person in the audience that I don't have a name for. And they're on a Dell computer of some sort. It's just listed as Dell Vetro 03 or something like that. And I
Oh, is it in
messaged
the chat?
you. Yeah, it's in the chat, and I put it in the chat, and I messaged them directly. But
Okay.
oh, thank you, Nicole. And then it looks like Michelle Georgie has a question. What is the moose doing post surgery? Moose?
Moose? I'm not sure what that
You
means.
can unmute yourself and ask the question. Go ahead.
Sorry, the triple the shoot, what's that stuff that we're sending with post-op TPLO surgeries? The
Oh,
man.
the wipes, the Duxa wipes?
Yes, please, thank you. Sorry.
I actually don't do that. So that, you'd have to ask one of the surgeons that does. You mean
Oh, okay.
sending it frequently for post-op TPLOs?
Yeah, I've been seeing more and more that they're sending the that mousse or the wipes home with these TPLOs and having them put it on for like 2 weeks on the incision, like once the bandage comes off. So I was just seeing what the purpose of that
Yeah.
was.
That's a good question. Honestly, I can ask, someone that does use them. I personally don't. I mean, I could see it being utilized maybe in especially allergy patients, right? That tend to get more skin dermatitis or inflammation secondary to a surgery, maybe just reducing contamination along that incision. But I can ask for you, figure it out.
Gotcha. Thank you.
You're welcome. Danielle, where did you, I can't find the question from the other.
That was
Oh,
Michelle's
that was,
question.
oh, Dr. Metallic. Yeah, I
Sue
can ask her.
said that Dr. Retallick sends that home.
Yeah, it may be, there are some people that will send, and I don't know that any of us do here. I personally don't, but there are some surgeons that will send still cephalexin as standard post-op TPLO surgery, or some more elective ortho procedures for, whether it's 5 days or 2 weeks. Oh, I was trained not to in residency. That's just because our ortho surgeons didn't, just to minimize any antibiotic resistance. But maybe a part of that is just because we don't want to do as many systemic antibiotics if we can avoid it, so that we're not inducing that resistance. So that Duxo mousse maybe is a better transition of, let's keep the incision itself, as reduced contamination as possible without having to give those systemic antibiotics, is my thought. Yeah.
And we are doing a talk next month on antibiotic stewardship, increased antibiotic resistance in the veterinary community as well. Dr. Vitalik is doing that talk. So that's definitely a good topic as well for this type of situation.
Yeah,
So
that'll tie in well. Right.
any other questions? I thought it was a great talk.
Thank you. Appreciate it. Thanks, guys. And I'm happy to,
All right.
to share this, or I guess it'll be posted, right? It'll be
Yeah,
posted.
we're gonna, I have your quiz ready to go, and for people who weren't here today. And then I'll post this link, and then anybody can either rewatch it or watch the beginning if they missed it. And then go from there.
Great. Thanks, Danielle. Thanks,
Yep.
everyone, for joining. I know it's hard in the middle of the day.
Yeah, thank you everybody for coming. It was a good
Thanks.
presentation.
Thank you. Bye, everyone.
Bye.